heart and beyond. So what we are going to discuss in this particular lecture is what is we have to do when we have to give a non-cardiac prescription to a cardiac patient, and we have to give a cardiac prescription to a non-cardiac patient, a non-cardiac disease. So how are your drugs are going to be changed? How are your approach is going to be changed? What are the drugs you have to select according to the non-cardiac situation? Or when the patient has got a cardiac disease in a non-cardiac situation, how you are going to change your cardiac prescription. So basically, we try to optimize these prescriptions. So as far as this lecture is concerned, I have a huge disclaimer. Nothing teaches us better than experiences. So whatever you may ask me, what is the reference, I may not be able to tell you. This will come with a pure experience. And of course, we'll give you some evidence regarding the statements we are making. So, of course, I also enumerate number of non-cardiac situations as far as the cardiac, along with the cardiac disease is concerned. Definitely, I still feel the list I'm going to tell you may not be complete at all. So now we look at a cardiac patient. The cardiac patient may have a congenital heart disease, valvular heart disease, hypertension, coronary heart disease, and cardiomyopathy, heart failure, and pericardial disease. And nothing of these cardiac diseases prevents him from having a non-cardiac disease. This cardiac patient is may have also diabetes, CKD, COPD, anemia, arthritis, GI disorder, thyroid, HIV, cancer, and neuropsychiatry, and also erectile dysfunction. So the problem is we may not be looking at only the cardiac patients, a cardiac condition, and treating that cardiac condition, but you must also look at what non-cardiac diseases this patient is having, and also what non-cardiac drugs this patient is having, how our cardiac prescription is not going to interfere or aggravate the existing non-cardiac disease, and also the cardiac prescription we give is not going to have a significant drug interaction with the non-cardiac drugs the patient is taking. So that is exactly the essence of my talk. So that's why we try to see how to optimize a non-cardiac and cardiac prescription when both coexisting. When both are coexisting, how you are going to change your cardiac drug and how you are going to change a non-cardiac drug. So first, the commonest, I take the diabetes, which is easy to understand. As you know, many times I told you diabetes affects the heart in form of pump because it affects the heart muscle itself, and it affects the pipe in the form of disease in the coronary arteries, and also it is going to affect the filter, which is the kidney. So all the three organs are going to be involved in a patient with a diabetes. So naturally, you have a multiple important information or multiple inputs you must have to optimize the prescription in a patient with a diabetes, whether it's got a pump disease, pipe disease, whether there is an associated filter disease. So the most important drug we use in diabetes is sulfonylureas. And for many years, in many studies, it has been shown sulfonylurea significantly increases the cardiovascular mortality. So that's why these drugs, although we use it very frequently, because this is a drug which is used for many, many years, and also it is a very cheap drug, and it is also a drug which is given free of cost in many of the general institutions. I will not say more than that. Some general institutions here, it is given free of cost. So if at all you have to use a sulfonylurea in a diabetic, please select glimepiride and gliclazide, which are supposed to be little more not so harmful. I will not so beneficial. I will say they are not so harmful as other sulfonylureas. So if at all you have to use sulfonylureas, but the fact you have to remember is there is no drug which can bring down your glucose more than your sulfonylureas. Many times, if the sugar is not under control, you have to resort to sulfonylureas to get the sugar down. If at all you want to use, it could be a glimepiride and glycoside in a patient with a cardiac disease rather than any other sulfonylurea, especially the older sulfonylureas. Then there is a question about the thiozolinodiones or glitazones in the heart. So we have already seen the glitazones will increase the weight and there will be a small reduction in hematocrit and there is increase in plasma volume. All this will exacerbate the pre-existing heart disease and they will precipitate a heart failure. So that's why it is very, very important to make sure you never give a glitazone in a patient with LV dysfunction or a significant heart failure. And of course, it cannot be given in elderly female where the patient has got osteoporosis, or it cannot be given an obese male where this is going to increase your weight. So that's why these drugs are very good when an young lean patient has got the diabetes with a normal left ventricular function. And this is the ideal patient you can give a glitazone. Of course, the latest sensation I will not go through because you should have heard thousands and thousands of lectures on SGLT2 inhibitor. But the two drugs which are going to be beneficial to the heart is likely to be SGLT2 inhibitor and GLP-1 receptor agonist. So the SGLT2 inhibitors is very good drug when the patient has got an already existing cardiovascular disease for the secondary prevention. And also they are the very good drugs when the patient has got heart failure. But GLP-1 receptor analogs play a very important role in prevention of stroke. So that's a very, very important thing, whereas the strokes are not reduced by SGLT2 inhibitor. So in that particular patient, your stroke is a concern, use receptor agonist, and heart failure is a concern, use SGLT2 inhibitor. So this is the important thing. So when you use this particular receptor agonist, the question comes, why don't we use DPP4 inhibitors? Because GLP-1 analogs are parenteral and they are costly. DPP4 inhibitors are less costly and they are given orally. But what you must understand is what we are trying to do is we have to increase glucagon-like peptide 1, which is a beneficial enzyme in a patient, not only in diabetes, but also in the heart. So when you use a GLP-1 analog, you actually increase the GLP-1 from the existing level. So actually you increase because you are giving more and more of GLP-1 analog, the level is increased, the body level is increased. Whereas when you give DPP4 inhibitors, what they are going to do is to prevent the degradation of existing GLP-1. That means you will make the GLP-1 levels normal, but not more than normal. Only GLP-1 analogs make the GLP-1 more than normal. That's why between these two, GLP-1 analogs have got the cardiac protection. If at all DPP4 inhibitor, one DPP4 inhibitor, which is cardiovascularly safe, but not beneficial, is sitagliptin. So if at all you want to use a gliptin in a patient with a heart failure, especially heart failure, it should be sitagliptin and not any other gliptin. So this is as far the diabetes and heart is concerned. So many times you have seen this slide. So whenever the patient has got a cardiovascular risk in the form of to protect the heart and kidney, dapagliflozin and empagliflozin are routinely given. We have seen many times what are the multiple benefits of the SGLT2 inhibitor by excreting the sodium and also the glucose. So they are going to actually decrease glucose and insulin, decrease sympathetic activity, they are decreasing the weight, they are actually decreasing oxide, decreasing our uric acid, and also they can decrease the blood pressure, and they are very good drugs to decrease albuminuria. That's why they are the best drugs to protect the heart and kidney in a patient with a diabetes. So now we come to what is the diabetic prescription we must give to a patient who has got already existing cardiac disease. So whenever the patient has got diabetes, coronary heart disease, and or heart failure, the basic two combination is likely to be metformin and SGLT2 inhibitor. So of course, GLP-1 as a receptor analogs also come into play if your concern is to prevent stroke rather than heart failure. So these three drugs, especially metformin and SGLT2 inhibitor, is a favorite combination. But many times metformin and SGLT2 inhibitor may not control your sugars to the effective level. So always you have to add a third drug. And what should be the third drug is this sort of practical application or a practical implication. So the third drug is likely to be glitazone when the patient is young male and has got a lean male and has got no LV dysfunction. When the patient is obese and he has got recurrent episodes of hypoglycemia, post-menopausal female, it is likely to be GLP-1 analog or DPP-4 inhibitors, but the preference is GLP-1 analog. When the patient cannot afford and he has to get drugs from the general hospitals only, then of course you can resort to sulfonylureas like glimepiride and gliclazide. Whenever your fasting sugar is normal, but you have a significant increase in postprandial sugars, the best drug will be alpha glucosidase inhibitors, or you can use metaglyptins. So metaglenides. Then of course, the patient prefers, the best thing will be insulin. So this is how you select the drug as a third drug in a patient with a diabetes and heart disease, metformin SGLT2 inhibitor, or in some patients GLP-1 analog. But of course, after that, the third drug, if you are taking metformin SGLT2 inhibitor, the selection of third drug depends upon so many variables. So you have to individually select that particular drug. So what are the concerns when you prescribe a cardiac drug to your diabetic patients? Don't use the atenolol, propranolol, and metoprolol. Avoid thiazide diuretics like thiazide and chlorthalidone. Always use indapamide. AC inhibitor, ramipril and perindopril are good. As far as ARB is concerned, telmisartan is good because it's a bimodal telmisartan, because it is going to block your angiotensin receptor, and also it has got some effect on the glucose lowering. And that's why the telmisartan is a bimodal sartan. And of course, the beta blocker is carvedilol, the diuretics indapamide. Statin should be used for primary prevention, even when the LDL is equal or more than 70. Aspirin should be used only in intermediate risk patients and not low risk patients. High dose, there is a concern of high dose statin induced new onset of diabetes mellitus, but the benefits of preventing cardiovascular disease is much more than the new onset diabetes mellitus. That's why we are using high dose statin in a patient. Make sure the patient is losing weight, the patient is regularly exercising, the patient is on strict diet control, so that your pre-diabetic patients, you must take good control of lifestyle, and so that he does not develop a diabetes in future. Then we come to the combination of kidney disease and heart disease. So the fact you have to understand, 50% of heart failure patients they will develop ultimately this CKD, which is called cardiorenal syndrome type 1 and 2. 40% of your CKD patients will have heart failure. That means cardiorenal syndrome 3rd and 4th. So you must also realize the most important organ you have to protect to reduce mortality is once again cardiovascular disease. So many of the patients with a CKD don't die of kidney disease, they die of cardiac disease. So what are the important practical implications? Many of your kidney patients will be getting erythropoietin, that itself may increase blood pressure. Therapeutic calcium does not interfere with calcium channel blockers. At the same time, don't give a large doses of calcium for a very long time. N-acetylcysteine is safe to the heart. When you use AC inhibitor, ARB, and calcium channel blockers, in a patient with a known kidney disease, please always watch for blood pressure, potassium, and also calcium blocker-induced edema. Always do a serial GFR. Whenever the serial GFR is falling more than 15%, you have to consider stopping or reducing ACE inhibitor and ARB. So always check nephro prescription before giving a cardiac prescription, because many of the drugs are hypertensive you are prescribing. The nephrologist also would have prescribed that particular drug. So there may be a double dose of a single drug. So now the gout will be a problem in patients with kidney disease. So when you want to use the uric acid drugs, and along with the uric acid drugs, and you have to use what uric acid drugs you must use will be allopurinol rather than febuxostat, because febuxostat will actually increase some sort of cardiovascular mortality. So that's why allopurinol is the best drug for relaxing a uric acid agent in a patient with a heart disease. And of course, the new potassium binders like patrinormer, SZC are there. Thereby, you can use ACE inhibitor and ARB without the fear of hyperkalemia. So the important word about uric acid and hypertension. So whenever the uric acid is high, don't use thiazide diuretic, because thiazide diuretic is going to reabsorb uric acid, and the reabsorption of uric acid is great with thiazide diuretic. And one antihypertensive you must use whenever the patient has got hypertension and high uric acid is losartan, because the losartan has got the type specific or the agent specific uric acid accretion effect. So that's why the high uric acid plus kidney disease and hypertension, it is losartan. So now what should be your cardiac prescription in a known kidney patient? So before you giving a cardiac drug, always calculate eGFR, and ACE inhibitor and ARB you are using for hypertension can be continued, but provided keep checking creatinine, keep checking potassium, keep checking GFR. So please make sure that when you have to stop ACE inhibitor and ARB, when these parameters are going out of control. When you use an aldosterone antagonist for heart failure with a CKD, always watch creatinine and potassium. And don't use rosuvastatin, try to use atorvastatin in a patient with kidney disease. So the best beta blocker we believe today is a benidipine, along with the ACE inhibitor and ARB, because benidipine has got additional effect on the excretion of albumin. So that's why it is preferable to use benidipine along with ACE inhibitor and ARB. Always use a loop diuretic whenever the GFR is low, not a thiazide diuretic. And one thiazide-like diuretic you can use in a refractive fluid overload is metolazone. Of course, when the patient has got a kidney disease and heart disease, the best drugs are SGLT2 inhibitors, which are dapagliflozin and empagliflozin. To a very low level of GFR, you can use them safely. To the level of 20 to 25 ml of GFR, you can use these two drugs for protecting heart and kidney. And whenever you are not able to use ACE inhibitor and ARB because of hyperkalemia, then you can use nitrate and hydralazine for reducing afterload, because these two drugs also have the mortality benefit. And always, when the patient are oral anticoagulant, especially the Cosax target-specific oral anticoagulants, you have to check GFR and adjust the doses. And of course, there's a controversy of giving aspirin in CKD patients. So previously, nephrologists don't want to give an aspirin, but if there is an indication, cardiac indication, you can definitely give an aspirin. So the third non-cardiac situation is going to be obesity. So in obesity, it is very important which anti-weight reducing agents are safe for the heart. So many times the obesity reducing drugs are not safe for the heart. For example, you can take phentermine and topiramate, and topiramate has got no effect on the cardiovascular outcome. So many of your anti-obesity drugs do not have cardiovascular benefit. The only drug, anti-obesity drug, which has got a cardiovascular benefit is lorcaserin. The lorcaserin is reducing the composite cardiovascular outcomes, and it reduces non-fatal MI, non-fatal stroke. It can slightly increase the LDL cholesterol, and also you have a significant cardiac benefit. So if at all you want to use a drug for weight reduction in a cardiac patient, it is likely to be lorcaserin and not any other. We can see no other anti-obesity drug has got a cardiovascular benefit. And of course, you can see that in majority of your anti-obesity drugs, your heart rate is going to be significantly increased. That is a very important problem because this is going to increase your cardiac demand, oxygen demand. Then we come to the other obesity drugs. These are the primary obesity drugs, and these are the drugs which are used in diabetes, but also they can reduce the weight and obesity. So many drugs, GLP-1 analogs, liraglutide is very good in not only to reduce your composite outcomes, they got a cardiovascular benefit and they can reduce the weight also. And the semaglutide is actually emerging. The semaglutide is once again producing cardiovascular better outcomes, and also they reduce stroke and systolic blood pressure is reduced. And of course, the cardiovascular benefit is a little bit on the doubtful. So this drug has been proved very good, as reasonably good for a heart failure with a preserved ejection fraction. So the cardiovascular benefits are actually emerging. So the one GLP-1 analog you cannot use in a cardiac patient is lixisenatide. Lixisenatide should not be used because it is going to actually increase your composite cardiovascular outcomes. So this drug should not be used. Non-fatal MI is increased, non-fatal stroke is increased. So if at all one GLP-1 analog you cannot use in a cardiac patient is this. Then of course we come to the obstructive sleep apnea. So obstructive sleep apnea, you can think about the dangers of sleep apnea by remembering hearts. H stands for heart failure, E stands for elevated blood pressure, A stands for atrial fibrillation, R stands for respiratory hypertension, T for diabetic mellitus, S for strokes. So these are the diseases that obstructive sleep apnea can produce. So if the patient has got obstructive sleep apnea, what drug you should not use in a patient with a sleep apnea as far as the heart disease is concerned? So one drug you must always use will be, so I'm going to tell you what should be done when the patient has got OSA and cardiac disease. Avoid sedation. We can use aldosterone antagonists, which are very specific drugs for the obstructive sleep apnea. Use anti-obesity, especially lorcaserin, and not any other anti-obesity drugs. Avoid anorexic drugs and arrange CPAP if eligible. So these are the 5 A's especially. So this is how you select. Yeah. So you have to make sure the drugs you are given for OSA is not endangering the heart by using these appropriate drugs. And what should be a cardiac prescription in a patient who has got already an obstructive sleep apnea? The best drug will be SGLT2 inhibitors because they are going to lose weight and they have mild diuresis and they are cardiac and renal protective. Angiotensin inhibitors can be given, and aldosterone inhibitors got a specific role in OSA because they stop or decrease the aldosterone which is produced by OSA, and also they are going to reduce the edema in the upper airway. And always look for sleep apnea in a refractory angina, refractory heart failure, and refractory hypertension. So when apnea hypopnea index is more than 15, CPAP may be help. The drug you have to avoid will be the older beta blockers, such as the propranolol, atenolol, and also the metoprolol. So all these drugs should be avoided because these drugs are going to terribly increase your weight and thereby obstructive sleep apnea. Then we come to the lungs and heart. So basically when the patient has got a COPD, and what cardiac prescription you have to be careful. So what are the drugs you avoid when the patient has got associated coronary heart disease or CVD? How is it going to change your COPD prescription? So don't ever give a oral salbutamol, terbutaline in patient with the COPD. None of these oral drugs, because they will increase myocardial oxygen demand and worsen CAD and can increase the arrhythmias, tachyarrhythmias. Theophylline also can produce cardiac arrhythmias. The common arrhythmia theophylline produce is multifocal atrial tachycardia. So try to give the inhalation therapy and nebulizer therapy, and beta agonist therapy, even when inhaled, can produce a significant hypokalemia and arrhythmias. So when you are giving a good dose of beta agonist, always monitor potassium. And steroid therapy, when it is given for COPD, please remember the adverse events on the cardiac side. They can retain sodium and water. They can increase your blood pressure. They can worsen your heart failure. So that's why when patient is on steroid, they can also produce hypokalemia and arrhythmias. So whenever you use antibiotics, a quinolin antibiotic or a macrolide antibiotic, please don't forget to look at the QT interval. So avoid erythromycin and quinolins in a cardiac patient, because these two drugs can increase QT, and these drugs definitely should not be used when the patient is already on the cardiac side. Amiodarone and ranolazine, which also can produce increase in QT. Try to prevent hypoxia to some extent, because they can irritate the heart. So the most important advice in all COPD patient is to have a pneumococcal vaccination and influenza vaccination to prevent or exacerbation of heart failure. But the next question comes, when the patient needs a beta blocker and the patient has got a COPD, this we have discussed in the last class. So whether the beta blocker can be given. I told you once again, COPD patients are dying of cardiovascular disease. So you can look at the chart. The cumulative incidence of cardiovascular disease is much, much greater when the patient is not on a beta blocker, and adverse events on the cardiac side is much, much lower when the patient is on a beta blocker. So that's why the beta blocker in the COPD protects the heart and also prevent death due to cardiovascular disease. And most importantly, the beta blockers you have to use will be bisoprolol and nebivolol, especially bisoprolol in a cardiac disease, coronary heart disease and heart failure and tachycardia. Nebivolol, you can use it in hypertension, but if it's a CAD, it's likely to be bisoprolol. CAD and heart failure, try to use CAD, bisoprolol, rather than nebivolol, for the reasons I have mentioned in the last lecture. So when you select the beta blocker, how are you going to do it? You have to select highly selective beta blocker, like bisoprolol, and the ACC inhibitors and ARB are preferable when along with the beta blocker to control the blood pressure. Definitely avoid atenolol, metoprolol, and also propranolol and the diuretics, because they will dry up the circulation, increase the viscosity, and block the small airway. Digoxin in a COPD should be used very cautiously, because it can increase digoxin-induced toxicity. And a long-term amiodarone, please remember, when the patient is on long-term amiodarone, always check the pulmonary status, because they can produce irreversible interstitial lung fibrosis. So use amiodarone only if definitely indicated, and keep watching for ILD when there is an associated lung disease. Verapamil and diltiazem in CAD can be used instead of a beta blocker, provided the patient has got a normal left ventricular function. And the best drug will be bisoprolol. And if you are not able to use bisoprolol, select vilpiapam distriazine CAD plus a COPD. If the pulmonary hypertension is present because of COPD and carpulmonale, always add a PDE5 inhibitors like sildenafil. And one important caution is, if the patient is on nitrate, you must stop nitrate and start a PDE5 inhibitor. Don't give nitrates and PDE5 inhibitor together. If there's for example, the patient undergone stent and the patient is receiving dual antiplatelet drugs, and the patient is coming with a significant dyspnea, and you search the heart and you search the lung. Of course, no evidence in the heart and lung. Look at the prescription. It is ticagrelor. Ticagrelor itself can produce some amount of dyspnea. So if you are having a dyspnea in a non-COPD patient in whom you cannot pinpoint a lung disease or a cardiac disease, look at the ticagrelor and use and removal of ticagrelor will relieve dyspnea. Then we come to the anemia. How to treat anemia in a cardiac patient? So anemia treatment is according to the type of anemia. Iron deficiency anemia will be due to the nutritional load. Don't forget the gastric bleed in a patient who is on oral anticoagulant and the patient is on dual antiplatelet drugs. So you can give a parenteral iron at the same time iron, avoid iron overload. The better formulation of iron will be liposomal iron for the oral use because it has got no effect on the excitant. So separate timing of AC inhibitor oral iron is a practical thing because to some extent the oral iron can blunt the effect of AC inhibitor. So that's why give the oral iron in the morning and give AC inhibitor in the night. Non-normocytic anemia, suspect a COPD. When the patient has got a hemolytic anemia, see whether the patient has got a prosthetic valve which produces hemolysis. Iron deficiency, it is not iron deficiency anemia to be treated in heart failure. It is iron deficiency itself in the form of decreased ferritin and decreased transferrin saturation should be treated even though the hemoglobin is normal. Blood transfusion in a patient with LV dysfunction is only packed cells with a careful watching of heart rate, respiratory rate, and also the SpO2. And of course, the bleeding due to Tay-Sachs can also produce anemia, and it has got a different approach. And the reversal agents for TO6 Tay-Sachs are very costly. So treat anemia if present rather than increasing the diuretic. So how are you managing your cardiac drugs when the patient has got anemia? So the patient has got anemia and exaggerated heart failure, correct anemia rather than increasing diuretic. Your target hemoglobin in a cardiac failure patient is 12.5. And please remember, AC inhibitors and CCB itself can contribute to iron deficiency anemia. So very, very important thing to understand. These two drugs, which are used in many, many cardiac situations, can lead on to iron deficiency anemia. Dual antiplatelet drugs, oral anticoagulant drugs, always used with a proton pump inhibitors to avoid gastric bleed. So vasodilators are to be used whenever there's a postal hypertension, especially with anemia. Look for postal hypertension and reduce your vasodilators. Anemia can predispose to high output cardiac failure. I told you about the precautions you must take whenever the blood transfusion is going to be used. So many of you wonder, we know that the AC inhibitor can produce anemia because they can produce the reduction in the production of erythropoietin. Because AC inhibitors reduce erythropoietin, anemia may be happening because of the AC inhibitor itself. But people wonder why calcium channel blockers can produce anemia. The calcium channel blockers can produce anemia because of the erythropoietin resistance. So how the erythropoietin is going to produce the cell differentiation from a less mature cell to a mature RBC is done by erythropoietin, and this process of maturing the RBC by erythropoietin requires lot of calcium inside. So unless the calcium is there, erythropoietin may not be able to convert an immature cell into a mature RBC cell. So that's why the calcium channel blockers, by interfering with the action of erythropoietin, can still produce anemia. They can also reduce the iron absorption by means of DMT1 expression. So absorption is reduced and the cell differentiation is reduced by calcium channel blockers. So you have to always think of calcium channel blockers and try to modify or try to, if you are blood pressure control, try to take off calcium channel blockers. Then we come to arthritis in a patient with a cardiac disease, or how to modify the arthritis drug therapy when the patient has got already a heart disease.
So please remember, the patient may be using from a COX-2 selective inhibitor to a non-selective NSAID. So COX-2 selective inhibitor is celecoxib. Celecoxib is very selective NSAID, but the problem is this has got increased risk of cardiovascular event. So this should be avoided in a cardiac patient. And of course, other semi-selective NSAID is also bad in a patient with a cardiac disease. But what is little bit safe, relatively safe NSAID in a cardiac disease is naproxen, because it's a non-selective SAID and it can have no increase in the risk of cardiovascular. They can even decrease the cardiovascular events. Of course, the low dose of aspirin can produce significant cardiac protection in an indicated patient. So this is how you have to modify your arthritis drug when the patient has got a cardiovascular disease. So as far as the hypertension is concerned, when a rheumatoid arthritis patient has got a hypertension, the best drugs will be RAS inhibitors plus calcium channel blockers plus or minus diuretics. So please remember, don't use a classical rheumatoid arthritis like NSAIDs and steroids for the disease. Try to use disease modifying agents and like methotrexate for rheumatoid arthritis treatment rather than NSAIDs, and always prevent high dose NSAIDs when you treat rheumatic heart disease. So this is how you approach the arthritis drugs where the patient has got a cardiac disease. So arthritis prescription in a patient. So now the patient is cardiac drug and has got arthritis. We have told you avoid NSAIDs, COX-2 inhibitors, and definitely you have to use, if it is definitely indicated, use naproxen, and we told you the steroids and also what drugs to be used for rheumatoid arthritis. So once again, the CCBs can aggravate anemia. New generation CCB like benidipine may have less edema, and aspirin and steroids NSAIDs combination may produce GI bleed. So this is the cardiac prescription in a patient with arthritis. So in a patient with arthritis, your CCB is already there. Knees and the joints are swelling, the CCB aggravate the edema, but in those situations, you can use newer calcium channel blocker, benidipine. So aspirin and steroid NSAIDs combination may produce GI bleed. So when the patient is already on aspirin, so make sure the patient is not a very high dose of steroid and NSAID on the arthritis side. So whenever the patient is on oral anticoagulants, a small injury to the joint can produce significant hematoma. So you have to advise the patient regarding very careful lifestyle to avoid injuries. Difficult to treat hypertension and heart failure in a patient. Always look at the arthro prescription. Many times your blood pressure is not under control, heart failure is not under control, because the patient is taking COX-2 inhibitor, the patient is taking a good amount of SAID inhibitor. That may be the cause, and instead of increasing your hypertensive drugs and heart failure drugs, and remove the offending drugs, and you will have the benefit. Now we come to the gastrointestinal tract and the cardiac disease. And of course, how are you going to alter your cardiac, the gastrointestinal drug prescription in a patient who has got a cardiac disease? The PPIs reduce gastric bleed due to DAPT and oral anticoagulants. So the patient is on oral anticoagulant, try to put PPI. So no longer this controversy exists like omeprazole and clopidogrel. So please remember, when you use cisapride, it can produce significant QT prolongation, and use newer motility like etopride rather than cisapride. And the patient who had a gastric bleed due to DAPT, the most important advice is many times we treat the GI bleed due to aspirin and DAPT and don't look at and follow the patient. It has been shown majority of patients who bleed due to DAPT ultimately have the gastric malignancy. So the people who have gastric bleed due to DAPT should be followed by future gastric malignancy. So esophageal spasm can mimic angina, but it may respond to nitrates, and it takes a long time for the pain to come down. Please remember, it is not as if a particular pain is purely gastric and purely cardiac. Sometimes the coronary spasm can be induced by the esophageal spasm itself. So esophageal spasm and coronary spasm can exist together, which is called linked angina. So now we come to the cardiac prescription in a patient who has got a gastrointestinal disease. So please remember, when you use DAPT, so ulcers, GIPD, always use PPI. Cossacks are effective and safe indicated patient, and CCBs and ranolazine can produce constipation. So when the patient comes to constipation, try to remove these two drugs. Propranolol is a drug when the patient has got cirrhosis and portal hypertension. And as far as statin is concerned, there is no need to give a routine hepatic enzyme estimation. Only when the liver enzymes are more than 3 times of normal, you have to stop statin. And one antihypertensive you can give in a patient with a liver disease is atenolol. So because atenolol is excreted through the kidney. So whenever the patient has cirrhosis and a severe portal hypertension and ascites, very high dose of spironolactone is going to help you. And of course, long-term PPI is to be avoided, because we have seen prescriptions where PPIs are continued for 4 years, 5 years without touching them. So always use a short course than long course. So whenever the patient is got any drug, always look for the drug interaction, because the drug interaction goes through the cytochrome system. If the 2 drugs are using the same cytochrome system, there may be significant drug interaction. Now we come to the thyroid disease and heart. So first of all, let us see what are the differences between hyperthyroidism and hypothyroidism. Hyperthyroidism, anxiety, neurosis, psychosis, recurrent heart failure, pulmonary hypertension, atrial fibrillation, weight loss, diarrhea, hyperemesis, lithium, and amiodarone can produce hyperthyroidism. As for the hypothyroidism is concerned, depression, dementia, OSA, a low pulse rate, a very, very lethargic patient. Recurrent hyponatremia, you must suspect hypothyroidism, dyslipidemia, carpal tunnel syndrome, and amiodarone can produce both hypo and hyperthyroidism. So in these patients, the pulse rate is the most important clue, especially the sleeping pulse rate. If the sleeping pulse rate is high, it is likely to be definitely a hyperthyroidism. So what should be your thyroid prescription in a patient who has got heart disease, especially coronary disease? So many times you will be giving thyroxine supplement. So whenever you give a thyroxine supplement in a known coronary disease patient, always combine that with a beta blocker, preferably propranolol, because all your thyroid drugs will increase sympathetic activity. They will increase macroloxin demand. A patient with a coronary disease is likely to worsen when they put an L-troxin. So always cover it with a propranolol. Subclinical hypothyroidism is bad. So it can produce all sorts of cardiac diseases. Always look and correct thyroid diseases in LV dysfunction heart failure. Many times I have told you, one of the causes of reversible heart failure is thyroid disease. So whenever the patient has got unnatural weight gain, pericardial effusion, and bradycardia, these are the triad. Very different combination triad. When the patient has got weight gain and the patient has got a pericardial effusion, you expect the tachycardia. But instead of the patient has got a pericardial effusion and a bradycardia, think of hyperthyroid pericardial effusion. So according to thyroid function test, you adjust the thyroid dose. Don't give it too much. Don't give too small. Patient adherence and thyroid medicine is important, because most often thyroid supplements are lifelong. So any thyroid disorder, please check whether the patient is on amiodarone. So now we come to a thyroid prescription in a patient with a heart disease. So once again, when the patient has got atrial fibrillation due to hyperthyroidism, always use beta blocking drug. So these are the very good drugs which can actually act as an adjuvant drug in a patient with hyperthyroidism, because the non-selective propranolol is preferred in hyperthyroidism rather than the selective drugs. So once again, hyperthyroidism, check for amiodarone therapy. So prompt treatment of hyperthyroidism can significantly reduce future cardiovascular disease and also the symptoms. So half of the patient have got abrupt onset, concurrent onset of hyperthyroidism and angina pectoris. So complete resolution of symptom is going to happen if you simply treat hyperthyroidism rather than doing an angiogram and revascularizing the patient. So 30 to 40% of thyrotoxic patients, they have atrial fibrillation. And if it's a recent onset atrial fibrillation, a spontaneous reverse sinus rhythm also can happen when you correct the hyperthyroidism. So when you correct hyperthyroidism, the LV dysfunction may become normal, hypertension can become normal, and you can have the remission of cardiac symptoms, and also the atrial fibrillation can come to sinus rhythm. So this is as far the thyroid prescription in a cardiac patient. Now we look at what will be the cardiac prescription when the patient has got a thyroid disease. So as I told you, always add a propranolol if the patient is on hyperthyroidism. And also always the amiodarone can cause both hypo and hyper. So if at all you have to use amiodarone, you carefully keep checking the thyroid function test. So if there is abnormality, stop amiodarone. And atrial fibrillation in hyperthyroidism needs only a rate control, and ultimately correction of thyroid will convert the atrial fibrillation to sinus rhythm. And in atrial fibrillation, you have to use oral anticoagulants. And once again, as I told you in pathopulmonale, digoxin should be avoided in a hypothyroidism or hyperthyroidism because the myocardium is sensitive to digoxin toxicity. Pericardial effusion is usually self-limiting and may not require a big intervention. So, as I told you, in any patient with a CAD, acute coronary syndrome, pulmonary hypertension, and heart failure patient, look at thyroid and correct thyroid disorder. Many of these disorders will actually get better, and sometimes they can even revert to normal. So now we come to the other important condition like AIDS and heart. So mainly the HIV. The primary problem on the heart is dilated cardiomyopathy. I told you many times the worst prognosis of dilated cardiomyopathy is due to HIV cardiomyopathy. The problem of HIV and heart is HIV itself can produce cardiac disease in the form of dilated cardiomyopathy. But unfortunately, the drugs you use for the HIV, which is highly active antiretroviral therapy, which is called HAART, is associated with a significant improvement in HIV, all right, but they are going to increase cholesterol. They can increase triglyceride, increase resistance, abnormal obesity, and they are notorious drugs to produce metabolic syndrome. Not only this, but the protease inhibitors also can be shown to have increase in myocardial infarction. So that's why the relative contribution of medication, lifestyle, and the effect of HIV itself on cardiovascular difficulty is very difficult to elucidate. And now we are coming to the drug interaction when the patient is using HIV drugs. So diuretics are usually, there is no significant drug interaction because they are metabolized outside the metabolic system, which is using the heart therapy. Beta blockers, you can see it is metoprolol, they cannot be used. So they are going to be, there is increased concentration of beta blockers. So HIV with hypertension, don't use metoprolol and propranolol. Whereas when you use atenolol in a HIV patient, there is no drug interaction between atenolol and your HIV therapy. That's why the second indication to use atenolol in hypertension is HIV and hypertension. As far as calcium channel blockers are concerned, please see that they are going to increase calcium concentration, calcium channel blocker concentration. Angiotensin converting enzyme are supposed to be safe when the patient is on HIV therapy. At the same time, the losartan is going to have a significant drug interaction, and it is going to have a lower efficacy. And of course, when the valsartan is used, it is the best receptor blocker to be used in HIV because the drug interaction is supposed to have not happen with the valsartan.
So the drugs which you use on the cardiac disease, which will not have a significant drug interaction with HIV therapy, are diuretics, the atenolol, AC inhibitors, and valsartan. So these are the drugs you have to select when the patient is on HIV therapy. And of course, now we see a lot of patients with the chemotherapy develop cardiac disease. So when the patient is got a cancer and it is having a chemotherapy, especially the patient is receiving anthracyclines in the form of doxorubicin and daunorubicin, they can develop a dilated or restricted cardiomyopathy, not only in the immediate period after chemotherapy, even lifelong risk is there when the patient had a chemotherapy in the form of anthracyclines, especially when they received very high dose of anthracycline. A significant percent of patients can develop a future LV dysfunction. That's why it is said when the patient received chemotherapy and the monitoring for the heart is lifelong. And cyclophosphamide and trastuzumab is known to produce heart failure, but it is reversible. So the cancer prescription in a cardiac patient is to avoid drugs which can produce LV dysfunction if possible. So if at all you have to use a less dose, and after receiving this cardiac inhibited drugs for chemotherapy, serial estimation of heart is necessary, at least for 5 to 8 years, if not lifelong. DVT therapy and anticoagulants, when the patient is already on due to a cancer itself, check the cardiac prescription whether the patient has got additional dual antiplatelet drugs, because this anticoagulants will increase bleeding. On the heart side, the patient is taking DAPT. Chest wall radiotherapy and chemotherapy will have more cardiac complications like breast and lung cancers. For the breast and lung cancer, when they give radiotherapy, there is increased incidence of cardiac disease. Now, what will be our cardiac prescription in a cancer patient? So if the patient is going to receive chemotherapy and the chemotherapy is likely to produce LV dysfunction, upstream therapy of starting carvedilol, especially before starting chemotherapy, and some sort of ARBs like valsartan, can decrease the amount of LV dysfunction which is going to be produced by the chemotherapy. So that's why there are upstream therapies before starting chemotherapy to prevent LV dysfunction. So once the LV dysfunction is there, you use guideline-directed medical drugs. So there is a lot of cardiac drugs which are said to produce cancer, but none of these drugs are proven to produce cancer. So carvedilol, valsartan, AC inhibitor are preferred drugs when the patient is having cancer and also on chemotherapy, developing LV dysfunction. So these are the 3 drugs you have to use when the patient develops LV dysfunction due to chemotherapy. So now we come to neuropsychiatric conditions and heart. So now we tell you what is the impact of neuropsychiatric drugs on the heart. So when many cardiovascular agents themselves can produce fatigue and sedation, and the medication-induced mood syndromes like psychosis and cardiovascular for many cardiovascular drugs. Depression associated with the beta blockers, methyl dopa and reserpine. And of course, the propranolol is good for Parkinson tremor. So many of your cardiovascular agents may produce neuropsychiatric problems, but the one drug which will relieve a Parkinson tremor is metoprolol. So now, especially when you use the neuropsychiatric drugs, especially with the depression, lipid-lowering agents, there is a lot of controversy that the statins are producing depression. It is no longer true. So in many patients, cardiovascular medications may have beneficial effect on neuropsychiatric consequences. So clonidine can reduce attention deficit. Prazosin can be better for post-traumatic stress, and propranolol for anxiety and also akathisia. A very exciting development is on telmisartan. Telmisartan is being tried for a future as a future neuroprotective drug. So what will be the neuroprescription in a patient with a cardiac patient? DAPT in ischemic stroke and TIA. No antiplatelet drugs and statin in ischemic stroke or hemorrhagic stroke. So careful BP management in strokes. So cardiac side effects and active Parkinson drugs, you must always understand. So the statin should not be used in hemorrhage. I have written ischemic stroke. The statin should not be used in hemorrhagic strokes. So antiplatelet drugs and also the statin should not be used in hemorrhagic strokes. It's not ischemic stroke. It is the hemorrhagic stroke. You cannot use these two drugs. So please remember, these two drugs should not be used in hemorrhagic strokes. Right. Then, of course, Parkinson disease. So there are many of these Parkinson drugs have got significant cardiovascular interactions. The most important interaction these drugs are going to produce is going to be a postural hypotension. So especially the drug used for the migraine, triptans. The triptans are going to produce the significant increase in hypertension. So many of the ergot alkaloids can also, the appetite suppressing drugs and also the dopamine agonist can produce significant valvular heart disease, and important regurgitation can happen with a Parkinsonism drug. So many of your neuro drugs can produce even vascular disease. And triptans, which are used in migraine, they are going to produce vasoconstriction, can increase the myocardial infarction, and also they can produce spasm of the coronary arteries. They can increase hypertension. That's why you have to be very careful when you use a triptan in a patient with a cardiac disease. So when you use psychiatric drugs in a cardiac patient, please check whether the drug is going to produce prolonged QT. Clozapam is a very notorious drug to produce myocarditis, and the cardiac safety drugs are SSRIs. And obese patients, many psychiatric drugs may produce metabolic syndrome and diabetes mellitus. So that's why in these patients who are on psychiatric drugs, the lifestyle modification is necessary to prevent the metabolic syndrome. So once again, cardiac prescription in a patient with a psychiatric disease, avoid. So cardiac prescription when the patient is already on a psychiatric drug, please make sure that drug is not producing QT prolongation. So when the drug has got tendency to produce QT prolongation, avoid all your cardiac drugs which can produce QT prolongation. That is amiodarone, type 1A C drugs, antiarrhythmic and analgesic. Postural hypotension constipation can happen in a patient with CCBs. As many of your psychiatric drugs also can produce constipation. Volter beta blockers can induce depression, avoid sedatives. So please educate the attenders to make sure the cardiac drugs are taken at the right dose at the right time. So I told you about the propranolol and the anxiety. As for the erectile dysfunction is concerned, I told you the last time we have discussed extensively this. So as for the ARB is concerned, it is best ARB in ET is valsartan. So if at all you have to use beta blocker, it is nebivolol and also the bisoprolol. And the most important advice is before prescribing PD inhibitors like tadalafil or sildenafil, make sure the patient is not on nitrates. So that's why they should not be combined. So in any erectile dysfunction, avoid all these beta blockers, thiazide and MRA we have discussed in the last class. As for COVID-19 is concerned, so when you want to give an oral anticoagulant, check whether the patient is already on DAPT. When you want to give a steroid, make sure the patient is not developing further exacerbated hypertension and heart failure. So no longer AC inhibitor is the existing controversy existing. And when you use hydroxychloroquine, check for the QT interval. Keep on reassessing the heart during the course of COVID. Change cardiac prescription and severe evaluation of COVID as well as chemotherapy drugs. So that's why the important thing we have to understand in this lecture is various non-cardiac drugs can have off-target effects on the heart that may not be expected based on the knowledge of pharmacology. So that's why it's very important to look at non-cardiac drugs when the patient has got a cardiac disease. That's why thorough medication history is very important. In non-cardiac patients, look at the cardiac drugs. In cardiac patient, look at the non-cardiac drugs. So you know about the anthracyclines, how they can produce cardiac disorder, and you have to follow up the patient. So that's why the cardiac risk profile and relevant comorbidities, and also what are the core drugs the patient is taking, and whether this particular coexisting disease or the coexisting drug has got a potential to have an adverse cardiac effect, and also make sure they are removed or they are treated. So as far as the cardiac drugs are concerned, in the non-cardiac drugs, when are prescribing non-cardiac drugs, always look at the cardiac comorbid condition and non-cardiac drugs the patient is taking. So you must have a thorough knowledge of cardiac drug and their effect on comorbid conditions I have explained, and what is their interactions they are taking for this comorbid conditions. Cardiac drugs should not aggravate the comorbid condition. They should not have less, they should have only less or no interaction with a non-cardiac drug. So that's why appropriate modification of cardiac drugs to suit that particular patient who has got a particular comorbid condition and also having a particular drug for that particular comorbid condition is necessary. At the same time, by inappropriately modifying the cardiac drug, you cannot make the patient to go into a cardiac disease which gets exacerbated. That's why you must maintain a fine balance between how you protect the heart with adequate drugs, adequately indicated drugs, adequate doses of cardiac prescription. At the same time, this cardiac drugs is not aggravating a non-cardiac disease and not interacting with a non-cardiac prescription. Thank you for your patient listening. And I told you, and I want to end with this particular quote from Hoop: the best prescription is the knowledge. So when you want to give the best prescription for a cardiac patient, non-cardiac knowledge, non-cardiac disease knowledge is important. When you give a non-cardiac drug to a cardiac patient, cardiac knowledge is important. Thank you for your patience.
Thank you, sir.
Excellent, sir.
Thank you very much.
Thank you, sir.
Dominic. Thank you, Dominic. Any comment, Dominic? Anything you want to add?
ஜிஎல்பியோட வந்து நல்ல பெனிஃபிட் இருக்குன்னு சொல்லி சொல்றாங்க சார். பட் பிராக்டிகலா பேஷண்ட்டுக்கு எல்லாம் கொடுக்கவே முடியல சார்.
That's a practical problem.
கம்ப்ளைண்ட்ஸும் கிடையாது சார். இன்ஜெக்ஷன் சார், அது ரொம்ப கஷ்டமா தான் சார் இருக்கு.
So this is the advice to a very rich practitioner and a rich patient. But they have the best benefit actually on the cardiac side. Although we prescribe a lot of DPP-4 inhibitors, the only DPP-4 inhibitor which is safer to heart is sitagliptin. All the other drugs have got some effect on heart failure. Even vildagliptin is supposed to increase end-diastolic volume. So that's why the safest drug will be sitagliptin.
Yes.
Any Dominic, you want to say something?
Sir, after stopping the CCB, how many days it takes time to reduce the edema, sir? Because without prescription, patient having CCB for a long time, sir. They come with
No, if you give amlodipine, the long life of amlodipine will have some effect. So the
Yes,
patient maximum 1 week. If you give amlodipine,
1
the
week.
edema will come within a week. If the edema is not coming within a week, you have to look for other cause of edema, not the amlodipine.
Yes.
If Dominic, you think any other to be added, just inform me, because I'm not
Yes.
sure that the list is.
It's exhausted, sir.
It is complete.
They exhausted, sir.
It is exhausted.
And exhausting, actually depressing. எவ்வளவு தப்பு
Depressing.
இன்னைக்கு தான் தெரிஞ்சுக்கிட்டோம்.
Okay.
Valid point, RBB, classical RBB and QR RBB.
சூப்பர் பாயிண்ட் அதெல்லாம்.
அது எவ்வளவு நாளைக்கு நிக்கன்னு பாக்கலாம்.
இல்ல சார், அதெல்லாம் நிக்கும்.
அது பாட்டு இருக்கும் சார். நீங்க பாருங்க, இனிமே நாளைக்கு கேளுங்க சார், நாங்க சொல்லுவோம் சார்.
நிக்கட்டும். நாளைக்கு சொல்லுவீங்க, அடுத்த வருஷம் சொல்லுவீங்களான்னு தெரியாது. ரைட். தேங்க்யூ.
Thank you, sir. Thank you, sir.
Thank you. Good night.
Thank you. Bye, sir.
Thank you, sir. Thank you.
Bye.
என்னையும் ஆஃப் பண்ணா ஆஃபே ஆக மாட்டேங்குது.
சார்